Good evening and welcome to this evening's installment of our Global Perspective Speaker Series. My name is Mark Gwynn. I'm a Vice President in the International Group here at the Dallas Fed and Director of the bank's Globalization Institute, which organizes this series. I will also be the moderator for this evening's event. We've hosted about 35 of these events over the past 5 years, but this evening's online-only event is just the third time we've used this format in recognition of the new social distancing circumstances forced upon us by the COVID-19 pandemic. Our guests this evening are Dr. Robert Haley and Dr. Trish Perl, both of whom are affiliated with the University of Texas Southwestern Medical Center here in Dallas. Dr. Haley is Professor of Internal Medicine and Director of the Division of Epidemiology in the Internal Medicine Department and holds the U.S. Armed Forces Veterans Distinguished Chair for Medical Research honoring America's Gulf War veterans. He received his undergraduate degree from SMU, his MD degree from UT Southwestern Medical School, and served an internship and residency in internal medicine at Parkland Memorial Hospital in Dallas. He spent 10 years at the U.S. Centers for Disease Control and Prevention, and upon his return to Dallas, founded the Division of Epidemiology and Preventive Medicine. He has published over 130 articles in peer-reviewed scientific journals. He is a fellow of the American College of Physicians and of the American College of Epidemiology, and has served as senior editor of the American Journal of Epidemiology. Dr. Perl is Professor of Internal Medicine and Director of the Division of Infectious Diseases in the Internal Medicine Department at UT Southwestern, and holds the J.P. Sanford Professorship in Infectious Diseases. She received her Bachelor of Arts and Medical degree from the University of North Carolina at Chapel Hill, and a Master of Science degree from McGill University in Montreal, Canada. She completed an internship, residency, and fellowship in internal medicine at McGill University Royal Victoria Hospital in Montreal, and a fellowship in infectious diseases and clinical epidemiology at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. She was the hospital epidemiologist and the Director of Hospital Epidemiology and Infection Control at the Johns Hopkins Hospital between 1996 and 2011. She joined UT Southwestern in 2016. Dr. Perl has been a principal and co-principal investigator for studies on healthcare-associated infections, bioterrorism syndromic surveillance, and antimicrobial resistance for the Centers for Disease Control and Prevention. She has authored and co-authored over 150 peer-reviewed scientific articles. Dr. Haley and Dr. Perl will be interviewed by the president of the Dallas Fed, Rob Kaplan. President Kaplan joined the Dallas Fed as its 13th president and CEO in 2015, having previously served as the Martin Marshall Professor of Management Practice at Harvard Business School. Before joining the Harvard faculty, President Kaplan spent his business career at Goldman Sachs and retired as vice chairman of the Goldman Sachs Group. Tonight we will begin with a conversation between President Kaplan and Drs. Haley and Perl, and then we will open it up to audience questions. To submit a question, use the Ask a Question button located on the webinar player page. If you have technical issues during the event, you are welcome to dial into the phone number posted on the player page. But please note that the video will not sync with the phone audio. And with that, I will hand it over to President Kaplan. Rob?
All right. Thank you, Mark. And Dr. Perl and Dr. Haley, thank you for being here. And I want to thank, we've got, I think, well over 1,000 people joining this video conference. So welcome all of you. I guess if you'd asked me 6 months ago, Dr. Haley and Dr. Perl, that I think I would be interviewing you at this kind of event, it probably would not have necessarily crossed my mind. You are two very important leaders in our medical community and in the community generally in Dallas, and I think in our country. But it's clear from what we've lived through so far this year, the path of the coronavirus and how this unfolds and the role we all play is going to be critical to the economic recovery in the United States. And I've had individual conversations with both Dr. Perl and Dr. Haley. I talked to a lot of epidemiologists and medical professionals, as you can imagine, over the last 6 months, 4 months particularly. But I've been so impressed with my conversations with them, I thought it would make sense to have this conversation with the public and share a lot of what we've learned from them with you. And so with that, again, Dr. Haley, Dr. Perl, thank you for being here. Let's just start with the coronavirus itself. We've obviously had SARS, we had the swine flu, we've had other issues in this country, other epidemics. What makes the coronavirus so unique and has made it so challenging for us and the rest of the world? What's unique about this disease that's made it so difficult?
So this is Trish Perl. I'll take a stab at this and say, so coronaviruses are actually relatively common causes of respiratory tract infections or the common cold. Everyone who's listening has probably had it by the age of 20. And we usually don't get very sick. What was very unique about SARS and also MERS-CoV, which emerged in 2012. So SARS emerged in 2002. 10 years later, we got MERS. Now another 10 years later, we're having SARS-CoV. Is that these were not only coronaviruses, but these particular viruses have some unique characteristics. First of all, they're very infectious. They're what we call fit. And that allows that is basically our verbiage to say that they can infect one person to the next. Second of all, they attach to receptors that are in the lungs, unlike the other coronaviruses. And that's why they can cause a more serious illness. Third, they are new. So we have an entire population that has never seen these. They have no natural immunity. And fourth, like all respiratory viruses, these are very infectious. And at the beginning of these outbreaks, what we call the reproductive number, how many people do I transmit this virus to, was around 4. So every person who had COVID was giving it to 4 more people. Those 4 people were giving it to 4 more. So all of a sudden you have 64. And it was just very explosive. So there are a lot of reasons just about the virus, but also the epidemiology of respiratory viruses that make this difficult. And then finally, we don't have any kind of vaccine or treatment for this. And so our normal strategies to mitigate have not been in place, which means that we've gone back to the kinds of strategies that we used in 1918, where we really had the last extremely large pandemic.
I might add just one other characteristic of this virus. For unknown reasons, it has a really remarkable ability to provoke your immune system. So the people who get very sick in the intensive care unit, as they're possibly getting well, getting better, suddenly their immune system goes wild and attacks the body, and many people die in what we call a cytokine storm. A cytokine is an immune outpouring, and it just storms and sort of affects the entire body. It's like your immune system's attacking your whole body. And that's we see that in other cases, but this virus has a much more likely propensity to do that.
Okay. So we've talked a lot in our individual conversations about the recent resurgence in the virus that we're seeing, at least in the state of Texas. And just for those who don't know, many do, since Memorial Day, we've seen the incidence dramatically increase. The positivity rate on testing is increased, and the degree of hospitalizations, the number of hospitalizations has basically doubled in Dallas and has doubled in Houston, and that's driven the state to similarly dramatic growth in hospitalizations. I've noticed that the death rate, though, seems to be more muted. Why has this resurgence happened, and what can you tell us about it?
Yeah, just in the last few days, that's becoming a lot clearer here from the epidemiology of what's going on. What we're seeing since Memorial Day in the last several weeks is an abandonment of the social distancing and mask wearing, particularly by young adults. They are out partying, going to bars, going to wedding receptions, parties of all kinds, mixing with their friends, and we're seeing big crowds in the bars with nobody having a mask. And that explains why we're having just an outpouring of cases, but also why our ICUs are not filling up quite as fast as they were before, because younger people, of course, don't have quite as bad a time with it. Our ICUs are increasing in census, and that's bad. And we are very worried that in the next few weeks we may get close to filling. But I think that explains it. We just got a big segment of our population, more younger, who are just not trying to stop this thing.
Let's just ask one question. It was thought, and we'll talk in a moment about what can be done about this, it was thought that the weather may play a factor in this disease. Has that turned out to be the case, or is it unclear?
I don't think so. I don't think weather's having much to do with it. We were hoping that it would be like some other coronaviruses, that it would be very seasonal and it would go away in the summertime. But it's now warm weather, and it is not going away by any means. So we suspect that it will not go away. A second wave is out of the question because the first wave is just going to continue.
All right. So let's talk about what can be done. And let's start with masks. And we've had lots of conversations. And even when I first talked with you, I think there's been so much misinformation about masks, about how effective they are. And I know you've got very strong views on this. How effective are masks? What kind of masks should people be wearing? And to what extent should everybody be wearing masks?
So I can start, and then I know Robert has very strong feelings about this, but overall, and there are a couple actually now in the past week, very good studies that have come out that have looked at how effective masks are in the setting of COVID. And they are reducing infections about 70%. So highly effective. Let me just talk about what that means. If I wear a mask and others don't, it will protect me. What's the 70% indicate, I guess? So if you have 100 people, 70, let me think about how to phrase this. Essentially, it's going to reduce your risk of getting COVID by 70%.
If I wear a mask.
If you wear a mask.
Okay.
And what we don't know is if both people wear a mask, we think, in fact, some of the data suggests there's an additional reduction.
Okay.
So, but you wearing a mask alone reduces it 70%. That's a regular mask.
Okay, so let's talk about that. A lot of people ask, does it need to be N95? Can it be a cloth mask? Does it matter? The only real indication for N95 masks are in healthcare settings when you're talking about infectious diseases. We're not talking about chemicals, but so N95s are what we recommend in certain settings in healthcare, but in general in healthcare, we also are just wearing regular medical masks. Okay. Cloth masks, which are the other thing you'll probably ask me about, are a little bit less effective than regular masks, but more and more data are coming out suggesting that they are probably more effective. And interestingly, there are things you can do to cloth masks, like in addition put in the material that is used in nylon stockings to make those actually even more effective. Okay. If you're somebody listening, let me just ask one thing. If you're someone listening to this call and I want to protect myself, I'm an older person, should I go to the store and get a medical mask, or should I use a cloth mask? What's the best thing I can do?
Wear something. Whatever you do, wear something. They're both effective. Okay. We want you to wear something.
Got it. Okay, Dr. Haley.
Yeah, early on in the epidemic, back in March, there was confusing discussion of masks, partially due to the fact that we didn't have enough N95 masks, so we didn't want everybody to go out and buy them because then the doctors and nurses couldn't get them.
Right.
And also there was a focus really on protecting the wearer, which was really not known about cloth masks at that time. But since then, we've really changed the focus. And we know now not only does a cloth mask protect the wearer somewhat, it's really effective in preventing the wearer from broadcasting viruses to everybody else. And if 40 to 50% of cases of the illness, of people who are infected, if 40 to 50% never get symptoms, and the people who get symptoms are most infectious for the 2 or 3 days before they get sick. So the majority of the transmission out there is by just talking, laughing, yelling, breathing, people who are asymptomatic and don't know they have it. And that's why it's spreading so wildly out there. And if everybody wore a mask,
right,
almost all of that would be stopped, and both by containing it in the person who's infected, they wouldn't be spreading it to others, and the other people would be protecting themselves somewhat. And
right.
We've seen, there are 15 states now that have mandatory masking requirements in their states, and they give fines for people who don't wear masks in public. In those 15 states, after about 3 weeks of one of those mandates going into effect, the number of cases starts declining by 2% per day, 2 percentage points per day. And all of those states have now dropped their epidemics down to almost nothing by wearing masks as well as distancing. The combination of wearing masks and keeping social distance, and I don't mean staying at home necessarily. People can go out, but as long as they maintain the 6 feet social distance and wear masks, you should be able to reduce it according to the experience of those 15 states that have done it.
Okay. And you've said to me when I've asked you, if everyone in this country literally wore a mask, you think we could have full airplanes, people could go back, have full restaurants even, other than you need to be careful about the distancing, but you think we could get a long way back to getting back to our regular activities?
I really believe that. Now, those 15 states that have done this are down to that level where people can go. So I don't see why the rest of the states are any different, except perhaps other states may have populations that are less amenable to cooperating with everybody else. That may be the problem.
By the way, I've talked to somebody today who's probably listening to this call from Denmark, and she told me that Denmark has gone from 6 feet down to basically 1 meter, 3 feet, or 2 and a fraction, because they had so much success reducing the transmission. Let's talk about personal hygiene. And Dr. Perl, you made a big point with me about hand washing and how important that is. Why don't you comment on that also?
So hand washing is actually, one of the more important things that we can do. And I know that everyone thinks they're so sick of hearing about washing your hands, but both using washing hands as well as using alcohol hand gel have been shown to reduce, again, transmission of respiratory viruses by 50%. So you're 50% less likely to get a respiratory virus if you are commonly washing your hands. Why is that? You touch infected surfaces, then you touch your mouth, your eyes, your nose. And so it's just to really make sure that if you've touched anything contaminated, that you're not actually putting it in a surface where you could actually then get virus into you. So practically highly effective.
So first thing you do when you get home from being out, you should go wash your hands for 20 seconds.
Right. Absolutely. You don't know what you've touched. You've been in the grocery store, you've touched the card reader, you've signed for your credit card, whatever you've done.
All right. Let me go on to testing and contact tracing. We obviously are, on the one hand, have more testing here and in Houston through the state. Contact tracing sounds like more spotty in the state of Texas and nationwide. Why don't you comment on on how you think about testing and contact tracing? And I know you're processing a lot of tests at UT Southwestern.
Yeah, for many decades, way back to the 20s, public health has used testing and contact tracing to control diseases such as tuberculosis, sexually transmitted diseases, measles, and so forth, and we still use it in our health departments. But that's a very different context in that those cases, there are relatively few cases of those things, and so contact tracing is very practical, and thus it's very effective. Right now, we are so overwhelmed with COVID cases that contact tracing is having a very difficult time keeping up. And we're now starting to see, very unfortunately, that a large percentage of the people who are being called, the people who are the COVID patients who are sick, are not giving out the names of their contacts. The soccer moms are refusing to give the names of their kids who were at the birthday party where somebody, infected person, exposed them all. And when they do give them out, they don't give the contact information. So we are struggling in Dallas to make contact tracing work, mainly because we just are not having cooperation, the same reason that people are not wearing masks. And I think it goes back to very confusing messaging. Our leaders are giving very different messages, and so people don't know to take this seriously.
So what should our leaders be saying? If people, elected, appointed officials, including all of us here, are listening, what should we be saying, and what would you like to see happen?
Well, they should be, our elected leaders, when they talk, they should be wearing a mask and take the mask off to start speaking, and then put it back on before they exit the stage to demonstrate that they believe in this. In addition, they need to be unequivocal and explain why it's necessary and that everybody must do it. And then third, they need to mandate it. It needs to be mandated. Wherever you have an increasing rate of these infections, those 15 states that have controlled it, they all have mandated masking. The 31 states that have some kind of masking recommendation or partial mandate or whatever, those are having no effect. So it's clear we need mandates that are enforceable by fines. And in Miami just implemented one in the last couple of days where they've got a $500 fine, I believe, and a possible jail sentence for a misdemeanor. So
we're going to come back to this. We're going to come back to this at the end and talk a little bit more. But I appreciate hearing what we ought to be doing and what we need to be communicating. Let me hit through a few other things that are asked about. In many restaurants you go into, they check your temperature. How effective are temperature checks?
So this is what we call screening, and temperature checks are one form of screening. They are helpful in that if you do have a temperature, then it's a sign that you have some kind of illness and you should not be there. However, many people with COVID do not have temperatures. So to think that it's going to prevent anyone with active disease coming in is naive.
Okay.
So I can't say it's bad, but I don't think it's going to capture all of the cases. And so that's its limitation.
Do you have a sense or an estimate what percentage of people who have COVID never develop a temperature at all, or basically asymptomatic?
Well, the latest studies are range between 25 and 40-something%.
Okay.
So it's a sizable percentage. There are lots of people out there walking around with this potentially infective that don't know it.
And infecting their family members unintentionally.
And all their contacts, yeah.
And their coworkers. And
let me ask you about another thing that I get asked about a lot. Different types of tests. So we've talked about tests for the virus, and there's the test that you all process where you go into a drive-through or you go into a CVS, and then it takes a couple of days. It goes to your lab, result comes back. And then there are a couple other kinds of tests. One is a so-called rapid test, maybe even there's been a lot of conversations about a saliva test. How accurate are your tests, and how accurate are these other kinds of tests?
Okay, so there are two primary things we test for. The first is we test for the virus. Most of the strategies that are currently being used to test for the virus are what we call PCR-based. What we're doing is we're looking for pieces of the virus's DNA or RNA. It's actually an RNA virus. And then there are in that different ways of doing this PCR-based test. The most reliable are take a little bit longer. And so that's what's commonly used in hospital laboratories. And their sensitivity and specificity, how much disease they identify, when they should and when they shouldn't, depends on different platforms that we're doing the testing on.
But the point, it takes a couple of days to get that result.
No, it takes, depending on this, anywhere 2 to 12 hours, depending on...
Oh, really?
So,
faster.
Right. Then there are the rapid tests, or some of the rapid tests, which are also PCR-based, that take about 45 minutes. Those also are very sensitive and specific. Then there are rapid tests that are PCR-based but use a different kind of technology. Those are the less sensitive. Okay. And what happens in those is we have a lot of what we call false negatives. So when they're positive, they're good. Yeah. But if they're negative, you cannot be assured that people do not have the disease. In asymptomatics, it can be up to 50% we miss.
All right. So for those listening, I guess the main message I want to get, if you want to get tested, what should you do, and which of those tests should they likely be getting?
Okay. So that's just for active disease, what I've just talked about.
Just if you're out there and you want to get tested.
What you want to do is you want to get a PCR test.
And go where?
You can go to a hospital, to one of the drive-thrus. Okay. What you want to make sure is that they're using a test that's been approved by the FDA. So in what we call an emergency use, an EUA.
Okay.
Listen, all right. My view is I don't think you want one of those 5-minute tests.
Right. Okay.
Those are the ones that, and unfortunately, those have been used most for screening asymptomatic people, and that's where they perform poorly. That's where their sensitivity is low.
All right.
In our emergency room, we're using that, but we're using it only for symptomatic people. And if it's negative, we go ahead with a PCR test often.
Right.
So,
and,
all right.
Yeah.
Yes, a 5-minute test is not a good idea.
All right.
To go back to your question, nasal versus saliva.
Yeah.
Nasal's most sensitive. However, on certain platforms, the saliva is looking really good. You just have to make sure your lab has validated using the saliva. So that may be fine. Then the second types of tests we do are the blood tests.
Yeah,
those
antibody
are called
tests.
Serology tests. Those are for antibodies. Mm-hmm. And there are a whole bunch of different platforms out there.
And I don't think our audience needs to know about that, but I would like to know, just because we've talked about, let's say you have the antibodies. So what? What's the implications of that?
It means that you have had infection, and it's interesting for epidemiologists like Robert and I. We can take your plasma and you can give convalescent plasma. It does not guarantee that you have immunity to the disease. We do not know that at this point. So you should not think I've had the disease, I don't need to wear a mask, etc. We do not know that at this point, which is the important message we want to get across.
All right. So let's go quickly to treatments and vaccine, then we're going to take questions from the audience. Are there effective treatments at this point for this disease?
So there are several drugs that we're using. One is called remdesivir. People may have heard of it. It's an antiviral, and it shortens the duration of hospitalization. It is not clear that it's decreasing mortality, and there are ongoing studies that are looking at its use in different settings. So that is being commonly used, but we have a limited supply of that drug. There have been some other drugs that have been tried and look promising, and this is what Dr. Haley was talking about earlier. There's a viral phase of this disease, and then about 7 to 10 days into the disease, you get an immune response. And so we are using things that modulate the immune system. One of those drugs that's been looked very promising recently, although we're waiting for the paper, is steroids. There's been a lot of discussion about that. There are other antibodies that are also modulating the immune system. So we're using 2 classes of drugs, but only a few do we have published data on.
Right. Let me give you a bottom line of treatment is that right now we do not have a drug that we know to be effective.
Okay.
We suspect there may be some out there, and there are lots of research going on, but we don't know that's going to happen. And just like with vaccines, we don't have a vaccine, and we don't know when one is coming, if one is coming. So anyone would be crazy to say we don't have to try to reduce this epidemic right now. We can just wait until the vaccine or the miracle.
We're going to get to vaccine in a second. Let's just so no effective treatments yet. By the way, typical hospital stay with say there's 1,000 people currently in Dallas. I think the latest number published today is we're at 1,000 hospitalizations for COVID. What's a typical length of a hospital stay, and what percentage of those people would have to go to the ICU?
6 days, 30% at least at our hospitals, Parkland and Clements University Hospital, are going to the ICU. Wow. In the ICU, the average length of stay is 14 days.
Wow.
So,
but it can go up to a month.
And these long durations in the ICU are what really are impacting the access to medical care, because it's not only that we're getting a lot of people sick, but they're staying there for a long time.
And once they're in the ICU, it's probably because of the immune system response.
In general, yes. It's usually about 7 to 10 days into the illness where we start seeing that they're having increasing oxygen requirements, and that's when these patients get in serious trouble.
Okay. So let's go to Dr. Haley. You touched on the vaccine. There's been a lot of talk, and Anthony Fauci, I think I saw him say yesterday, he was hopeful later this year. I'll just preempt. I've heard from a number of epidemiologists I've talked to, as well as you all, that you think it could be much further away, even might not come by 2021, which I think would startle some people. What's your view on the likely timing of a vaccine for this disease?
There are 2 reasons for some optimism. One is that there are several new technologies that have not been used before and are used sparingly in developing vaccines, and those are being cranked in. And the second thing is there are over 100 laboratories working on vaccines and trying to turn out the miracle. So that's positive. The negative is we have never produced a vaccine in the history in less than 4 years. And the reason for that is, one, it takes a long time with a lot of missteps in developing one that looks like it might be useful. And then there are 3 phases of tests that you need to do, ultimately on thousands of people. And the problem is you can't shortcut that. Now, we can a little bit here because the disease is very common right now, and so you can get studies done more quickly when there's lots of disease to test with. But if you shortcut this, you take a big risk of having a vaccine that either turns out not to work out in the field, or worse, that it has some really bad side effect that you didn't pick up, and then you take a huge black eye, and vaccines lose their charm for the public. So you can't short-circuit it.
This is the so-called safety test. There's no substitute for time to see whether people develop side effects.
Yeah, it's safety and efficacy. So
Okay.
you want to be sure that when you get it out in the field out there and test it on a broad variety of people, there's not some group out there that's just not going to respond. And second, you want to be sure there's not some unusual side effect that turns out to be devastating. I mean, back in the polio days, there were lots of polio vaccine that actually caused polio, and people got paralyzed or died from the vaccine. And that was 50, 60 years ago. But and then the swine flu immunization campaign in the mid-'70s had to be stopped because of side effects of the vaccine after it was in the field.
So your message, I know both of your message to me was, we're going to have to learn to manage this disease without a vaccine and be prepared, hopefully it'll be sooner, but to do this for some extended period of time.
That's correct.
All right, Mark Wynn, let's go to you and let's start taking questions from the audience.
Okay, you hear me?
Yes, sir.
Okay, first question is still on the theme of testing. Do you have any insights or comments on the problems with testing in Dallas County? Why it has been so spotty and difficult for people to get tests?
Well, it's mainly the fact that we don't have testing supplies. Testing, as we all know, rolled out so slowly, and we're still having periods where we run out of testing supplies. Kits, we run out of kits, we run out of other supplies to run the big testing machines. So had we adequate testing supplies, we would be able to do a lot more tests.
So I understand that Texas is something like 46th in the nation out of 50 states in terms of testing availability. Is that accurate?
So if you look at the national data, that's about where we are in terms of the current number of tests that we should be doing per population, or that we have per population. The New York Times sort of looked at some data from Harvard researchers that suggested that we should be doing about 152 tests per 100,000, and we're doing around 40 to 45. So we have definitely some growth that we need to do in how much testing we do.
And is it your sense, and I'm part of a subgroup myself of community leaders trying to get more work, push for more testing, is it your sense that leaders are aware of this and are actively trying to create more testing capacity?
I think they are, but I think, as Robert pointed out, we also have supply chain issues that have complicated some of this, and then there's also access to testing and where you have your testing sites. So that's actually, to the previous question, one of the other challenges is making sure that we get testing sites in areas that they need to be.
So more widespread through the community.
Right, and they can't be concentrated in certain parts of the town, etc.
Right. Okay. All right. Next question, Mark.
Are there different strains of the virus out there, and would it make a difference for developing a vaccine or testing?
No, there's really only one strain, although it picks up little mutations as it goes, but so far none of those mutations has made any difference in how serious the illness is or how rapidly it spreads. So just one strain.
Okay, next question. How safe is public transit?
So in my mind, public transit is one of the areas that is least safe. The reason is that you're in a smaller space with a lot of people. So any setting where you're in spaces with lots of people and you may have limited circulation of air are going to be the most high risk. So I consider that a higher risk space in general. Now, if you can open windows and do other things, it's going to make it safer.
Our county government just last Friday passed a masking mandate for businesses, that businesses must require their employees and all their customers to wear masks. And I believe that is being extended to our mass transit. And if that is effective, getting people to wear a mask before they get on a bus or a light rail, I think that will greatly increase the safety, although it is a confined space and it'll be hard to distance, particularly at what rush hours. So I think unfortunately our necessary workers who are working right now, and our low-income people who have to work are selectively exposed to mass transit, and that's, I think, taking a toll.
Next question. Can the disease be transmitted through blood transfusions, or does your blood type have any relationship with your susceptibility to the disease?
So the answer, as far as we know, it's not transmitted through blood transfusions. However, there is some information that's come out in terms of looking at your susceptibility to the disease and the severity of disease that you can get related to blood type. And that's basically the type A blood is thought that these people not only are more susceptible, but also are more likely to have severe respiratory complications. Oh, sorry. Go ahead.
Okay. And type O is protective, although it's very interesting that they've looked at the genes where the blood type is carried in your genome, and that little segment of DNA not only has the blood type, but it also has a whole bunch of immunologic factors, some of which are playing in the COVID, in your ability to fight off the COVID infection or for your immune system to go wild. So it may not actually be the blood type itself. It may be its surroundings in the genome. Very interesting.
Okay.
Next question. What do we know about the long-term outlook for people who survive? Do they have any permanent health effects?
Yes, that's something that's becoming clear as we learn more about this. And the problem is this disease affects your entire body. And while you're in the throes of a severe illness, particularly if you're in the intensive care unit, you can have kidney failure, you can have heart problems, including heart attacks or strokes, or even if you don't have those things, you can develop a long-term reduced ability to breathe well, lung capacity, and you can also have a sort of a long-term chronic fatigue syndrome type thing that indicates some kind of probably inflammatory process of the brain. So yeah, people particularly who are very sick with this will have lingering problems, and we don't know how long those are going to go. Of course, we only have 3 months of experience.
Can I jump in here? Let me ask you one question. Just is there a country in the world or countries in the world that are handling this particularly well that you're looking to?
Oh, yes. A lot of countries. Most of the Asian countries have pretty much wiped it out. And, those are countries, I think there are 12 Asian countries that have pretty much wiped it out. China, Singapore, Japan, et cetera, et cetera.
And I've told Denmark is basically in the same situation, pretty much wiped
Denmark,
it out.
Germany, Italy. Italy is,
So what are they doing right? What are they doing right that we're not? They've got extensive mandates for mask wearing, testing, contact tracing. What are we doing wrong?
Masking.
Sorry.
Yeah, masking, contact tracing. The Asian countries have 40, 50, 60 years of tradition that when people get a common cold, they wear a mask. If you've been to China or Japan or any of the Asian countries, you go down the street and you see an occasional person with a mask, and you ask your colleague there, why do they have a mask? Oh, well, because they have a cold.
Right.
And so also with SARS struck Asia pretty hard. They learned that they can stop SARS by masking and distancing. And so the population all falls in line. Like they have 96 to 98% compliance with masking in China and Japan. And so if we had that, this thing would go away.
So, it's also very important to point out that in these countries that have been successful, it's not only the individual measures, but it's also that they had much longer durations where they had shelter-in-place orders, where they were really limiting any kinds of interactions. They had robust health systems that were much better prepared to do the contact tracing. And if you look at the proportion of tests that they were doing and how they were managing their clusters, they really had a lot more of this sort of infrastructure in place to support all of this. And I think that's been also one of our challenges. We just didn't have all of this in place and still don't.
I think an interesting way to look at these different measures, we can have everybody shelter at home and not go out. But what that does, it shuts down our economy, as we've seen.
Yeah.
And we're going to drive ourselves into a depression by sheltering at home, when if we would just mask, distance, cut this thing down enough so that testing and tracing could really snuff it out, we could go back about what we're doing, as many other countries are starting to do now, and not get in trouble. But as long as the people, a segment of the population out there refuses to go along with this, we're going to have to be sheltering in place, stopping our economy, and going into a depression. And so the people who are not wearing a mask are the ones who are keeping our economy from opening.
Okay. Mark, back to you.
Next question. Can you comment on why communities of color seem to have been disproportionately affected by this?
I think the general sense in this is, first of all, a lot of these groups tend to have what we call critical infrastructure jobs. They're doing a lot of these jobs that require face-to-face contact. Whether you're talking about working in grocery stores or construction or in any of those kinds of settings. So that clearly they have the exposure, if you will. Second thing is they also have not had access to testing, as well as other support that you need to actually diagnose and then get appropriate treatment. Additionally, they've been in the kinds of jobs that haven't allowed them the luxury of isolating and quarantining. They also tend to live in communities where they have larger households or have households with more people in them. So again, it's that crowding that's really contributed to the testing. Whether or not there's economics that's playing into this, I think there are certainly data out there that suggests that's also important in all of this. But it's really been a very mixed picture. And at this point, that's been probably the most important driver of this, if you will, in those particular communities.
Yeah, right now we're seeing a lot of instances where young people are out partying, disregarding the masking and distancing. They get infected. They don't get very sick, but they come home and they infect their family, and they have these large, very coherent families, which normally are a great asset. But then this thing just spreads through families, and our hospitals are seeing one member after another of a family coming in. So I think that's contributing.
Next question. Is getting on an aeroplane as dangerous as getting on a city bus?
I don't think so. I think the airlines have done a very good job. One, they're mostly requiring everyone to mask when they get on a plane. And also, when you get on a plane, it's a little bit drafty, if you've noticed, because there's a lot of air changing going on, a lot of ventilation in the cabin of an aircraft. And when the air circulates up into the ceiling, up into the vents up there, it goes through what's called a HEPA filter. That's a high-efficiency filter that filters out these particles and the viruses. So the air is relatively clean, and if everybody's wearing a mask, that's good. Now, if you're sitting next to somebody who's sweating and coughing, I'm not sure how safe you would be, but as long as that's not the case, I think it's probably relatively safe.
Okay, this is a topic we've gotten actually a lot of questions on. School reopening in the fall. Thoughts, how to manage school reopening, primary, secondary, third level?
Well, there are some recommendations that are starting to come out right now. And they are recommending that all the school kids wear masks, and that the school arrange for distancing in the classroom, and that we perhaps will curtail sports where people would mix, and that we take measures to protect our teachers particularly. Now, one of the advantages we may have, is that you remember the virus attaches to this little thing on the cell in your lung, this thing called the ACE2 receptor. It's a little protein on the surface of the cell in the lung and some other parts of the body. But it turns out you have to have those ACE2 receptors for the virus to attach so that it can go into the cells and infect you. But it turns out that children have relatively few of those. Those mature as you go through puberty. And so now the evidence is not airtight yet, but an article just came out the other day showing that these increase over your lifetime, which may indicate why elderly people have a much worse time with it. They may have more of these, but they've just done a study that finally went down into young childhood, and sure enough, about 15 to 17 age, you start getting less and less of this ACE2 receptor. So it may be that most children just really don't get it, or if they do, they get a very mild case that maybe isn't as infectious. Now, let me not give us a false sense of security. We don't know that for sure. But that's the way the research is trending right now. But I think in the next few weeks, we're going to see a lot of recommendations. I know the CDC is just about to release some recommendations on school openings, and other groups are working on guidelines as we are in Dallas. So that'll be clear in the next few weeks.
I'll just add a couple of points. So I think, as Robert was saying, I mean, they are really making recommendations about personal hygiene, and this is going to include things like alcohol, hand gel in classrooms, about physical distancing and rethinking, for example, even lunchrooms and what we're going to be doing in lunchrooms and how we're going to be serving lunches to kids. So you're going to see the physical distancing, you're going to see, masking versus hand hygiene. The other things I would just sort of point out to the audience that is coming out in a different type of research that's being done is what we call modeling, where we are looking at the impact of different types of interventions. There is some suggestion that, for example, if we stagger how kids come in, that may help. So we actually may see strategies where we have kids for 1 week and not for the next, and then we'll have kids for another week and not for the next. And this is moving so fast that what we say today may be actually different in 3 weeks from now. But just to recognize that we actually really may rethink what school looks like and how it looks, or we may have different groups of children going to schools in different weeks, just again to have some additional distancing and to minimize the spread. If one classroom gets sick, then we're not going to infect all 1,000 children at that school.
Another question from the audience. Is there any significance to the loss of taste and smell as a symptom of this disease, or is this just a characteristic of this category of virus?
Yes, this is very interesting. It was a very unexpected symptom to come up. We do see it uncommonly, but we see it in elderly people and in some other virus diseases, but it's very rare. It's relatively common. I just saw a figure the other day. It's, I don't know, Trish, did you see this? Something like 60% of COVID patients lose their sense of smell. And a lot of times it comes on before the symptoms, the other symptom, maybe the first symptom of the illness. And so right now we are teaching that if a person suddenly loses their sense of taste and or smell, that should be a sign of this disease regardless, and that that would be an indication for getting a test because it means it means they're about to break out with symptoms or not, but they are probably infectious at that point. So there's a most interesting study in Britain and the United States. There's a collaborative study using a smartphone app that was developed in the UK for another purpose and is repurposed for this, where young people particularly can put the app on their phone. Every place they go can have one of those little CR codes, a little postage stamp code that you scan with your computer, your smartphone. You can scan wherever you go, like if you go to a party or you go to out to dinner or you go somewhere, you scan their code, and everybody scans their code. And then if anybody gets sick with COVID, you put that in your phone, and it automatically sends an alert to everybody who's crossed your path in the previous several days, and warns them that they have been exposed and that they should quarantine, gives them instructions about what to do. And they found in analyzing the first 2.5 million records in that people in that database that loss of sense of taste or smell is the most important sign for identifying people early with the disease. More important than fever, cough, chest pain, et cetera, et cetera. So that is turning out to be a huge clue that we may be able to capitalize on. And I think the development of smartphone technology, and we're starting to use automated technology similar to that for our contact tracing, although it's not going very well right now due to cooperation. But smartphone technology may really be useful and we need to get better at this, because COVID may not be the last coronavirus we see. If we beat this one, these things, it's SARS, MERS, and now COVID, this is the third severe, damaging, devastating coronavirus we've seen in the last 20 years. And so we're bound to see more. It looks like they're maybe speeding up some. So we need to get good at this. So we don't close down our economy every time.
Dr. Perl and Dr. Haley, we just have a few minutes left. What if you had to give one message, and I think I know what it would be, but I want to give you a chance to say one message to all the people that are listening and to leaders in this state, which we'll work to help reinforce afterwards also. What would be that message?
Well, my message would be we need to open our economy up, and getting our GDP back where it was is not going to work by just opening businesses. Opening businesses do not create GDP. It's consumer spending that creates 70% of our GDP. And so I'm sure you'll appreciate that.
Yeah, I like that.
But as long as we have most of our consumers hiding out in their home because they're afraid of getting a fatal illness, they're not going to be spending. and our economy will stay shut down regardless of how many businesses we have open up. And the way they can get out, the only way they're going to get out is if we drive this epidemic down to a small level so that contact tracing can snuff it out. Then people can come out and start spending. And the only way we can do that right now is with masking, distancing, and personal hygiene. And right now, we do not have enough buy-in by the public to do that. So right now, for the foreseeable future, we're going to have our economy closed down. We're going to go into a depression, and people are going to start losing their jobs. And so we need to get everybody to wake up. This is like World War II. Our whole country needs to get behind this, and that means our leaders need to start consistent messaging, demonstrating wearing masks and distancing, and getting everybody to do this, or we're just going to be, we're going to lead the world in how deep a depression we can produce, while Europe and Asia recover and start taking over. I mean, that's the message I have.
Dr. Perl?
So my message is that we really need to take this seriously, that even though not everybody is getting seriously ill and some people are actually asymptomatic, that we are seeing a lot of significant disease. And honestly, it's tragic. I mean, the stories that I can tell you, having worked in a COVID unit, it's very, very sad. These are people who are like all of us. They are out there working and trying to contribute to society. So we need to take this seriously. Second thing is that we don't have a magic bullet right now to prevent this. And so we now are looking towards all of us to take some personal responsibility in this. And as Robert said, we need to be masking, we need to be social distancing, we need to be washing our hands. And we're not only doing this for us, we are doing this for all the people around us, for our grandmothers, for our, the person next door who we don't know has cancer but does, and everyone else. And, we shouldn't have to be mandating any of this. We should be doing this because it's the right thing to do. And it is ultimately going to help us get out of this more quickly. If we don't do this now, it's only going to get worse. And we know historically from 1918 that people who did this right and took it very seriously and did it consistently are the ones who ultimately actually fared much better from a socio as well as an economic point of view. So I think it's very, very important. And then, the final thing that I'm going to say is that this is a marathon. It is not a sprint. There's not a rapid fix to this. And even in the setting of getting vaccine tomorrow, we will be talking about a recovery that's going to require a period of time. So we need to get out of this mindset that we can just snap our fingers and it's going to happen tomorrow. We are going to be wearing masks and doing all of this. This is the new normal for the foreseeable future. And we need to message that.
Dr. Perl and Dr. Haley, thank you for your leadership. I've got my mask right here I'll be wearing as I leave the door. I hope everybody does this, because I'm convinced that we don't need to have a second wave, that we can manage this, and it's in our hands. So thank you for your leadership on this. Thank you for all you're doing, and I hope that we'll act on a number of things you said tonight. And thank you everyone for participating. We're going to do another one of these events coming up over the next few weeks with Marta Van Odom, who is the leader of the economic recovery efforts and testing efforts for the city of Houston. And we look forward to doing that event. Mark Wynn, thank you for everything. And thank you for your work on this, and Jenna Dillenbach. And with that, I'll wish everyone a pleasant good night.
Thank you for having us.
Thank you. Good night.
Thank you.